I think we're at a really exciting time with EOE, with the number of compounds that are being developed for treatment of EOE. And one of the reasons for this is we have learned so much about the pathogenesis of the condition. And we know that EOE is a Th2 triggered process, typically from food or less commonly environmental allergens in the setting of some defects in the esophageal barrier. And this starts just the typical Th2 pathway with alarmins and then cytokines like IL-4, 5, and 13, on and down the cascade to where we have eosinophils and mast cells as effectors. And with that, at almost every point in this pathogenic cascade now, we have a possible treatment target, and many of these are under development. The first set that I would mention are the biologics. Now, these are typically monoclonal antibodies, and a number of them are targeted either at receptors or at the cytokines themselves. So we have a number that are in testing and a number of possible options as well that are either under development or there's reasonable proof of concept based on mechanism. The ones that I would mention to you are, in terms of the cytokines, are the anti-IL-5 medication like mepolizumab, the anti-IL-13 medication like cendakimab. The cendakimab has just started a phase 3 program. Then we've got the receptor type targets, such as the anti-IL-4 receptor alpha target, which is dupilumab, focusing on the IL-4, IL-13 pathway. We have benralizumab focusing on the IL-5 receptor, and most recently, the anti-Siglic 8 antibody larentelimab. There are also, in addition to biologics, small molecules, and some have been examined, and some newer ones are just being examined in phase 2 studies. This would include the small molecule etrasimod, which targets lymphocytes and potentially traps them in the lymph nodes, as well as a newer molecule termed 1104 right now, which seems to interfere with antigen presentation at the macrophage dendritic cell axis. Both very interesting, and we'll wait to see whether there's any proof of concept in the early phase studies. Now, a number of these are quite far along in drug development. So where are we in terms of phase 3 agents? These are biologics that are in phase 3 right now, and they include dupilumab, where the phase 3 studies are finished and we're waiting for some of the final data readouts. The benralizumab and cendakimab trials are underway, and we just received recent top-line data on the larentelimab trials, where one, but not both, of co-primary endpoints was met. In addition, topical steroids are also completing phase 3 evaluation. So some of these medications are quite late in development, and we will wait to see how they turn out. Now, with all of these new options, it's really interesting to think about where these treatments may come out in our EOE treatment algorithm. We don't have all of the data yet, but I think it's easy to think about the first place these drugs will be treated, will be used is in patients who are steroid refractory or other refractory to other treatments, or potentially intolerant to treatments. Right? If someone is not responding to first-line agents, the PPIs, the topical steroids, diet elimination, then these novel agents are really quite a good fit. But as we get more data, do we think about moving these up in the algorithm if they're safe and very effective to either allow for people who haven't had any first-line therapy or even for treatment-naive patients? And then it's also interesting to think about the role of these medications in long-term maintenance, and if there are antifibrotic effects, could they be best targeted in patients who need dilations or have strictures?